IJCP stands for?
So it stands for Indian Journal of Clinical Practice.
Okay.
Yeah. So good evening, everyone who have joined our platform for better exchange of knowledge. I would like to welcome all the viewers who have joined our platform. This is Shreyan from IJCP, today's moderator. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Narendra Rungta. Sir is MBBS, MD, FCCM, FICCM, FISCCM, Chairman and Managing Trustee of Critical Care Foundation. Sir is also a past President Associate of SAARC countries, Critical Care Societies. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is managing the unseen threat aluminum phosphide toxicity in clinical practice. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Shreyan. Good evening. I'm thankful to IJCP for inviting me to this wonderful platform of public importance. Good evening to the viewers and to the listeners. I am going to talk about aluminum phosphide poisoning. Popularly, it is called sulfose poisoning also. And when we were postgraduate students of medicine, sulfose poisoning means death. If somebody had consumed sulfose poisoning, that means death is certain. There was no treatment. There was still no treatment, but uh, quite a few of these patients can be saved. So this presentation of mine today is based on the guidelines on poisoning published in form of a book by Indian Society of Critical Care Medicine last year, February, and a position statement that we published in Indian Journal of Critical Care Medicine this year, which was published in the month of August. Review of almost 80 plus articles in various journals on aluminum phosphide poisoning, and our paper, which is on way to be published soon in a reputed international journal about ALP poisoning. So this is the book that I was talking of, and this is available in the ranks of Indian Society of Critical Care Medicine on the publisher also. I had the privilege of being the chief editor of this particular book. So let's move on. Poisoning is a very significant killer in India, in developing world. The developed world is also not immune to deaths from poisoning or morbidities from poisoning, but the epidemiology is different. Globally, more than 3 million of acute poisoning, probably now much more than that. This looks like an iceberg, and this is an old data. Yearly deaths in India are estimated to around 5 to 6 per lakh population due to acute poisoning. It is the fourth most common cause of mortality in India. You can understand heart attacks, cancers, diabetes, infections, and poisoning, road traffic accidents. So this is one of the top causes of death in India. The important thing is it involves middle-aged groups who are under stress, who are under tension of various kinds, which are financial, social, etc., etc. Poisoning patients are mostly, middle-aged, 40 to 50, housewives or earning members of the society. My experience shows that there are four commonest poisons in our country, and the three most common are aluminum phosphide, organ phosphorus, and snake bites. Together, three of them, they almost constitute more than 75% of all poisons. About 20 years back, it was said that probably aluminum phosphide's use will be eliminated through legal means. There were lots of appeals in Supreme Court of India against its marketing, but now we see that its use has only increased. and it is projected that it is going to increase 5% every year in the world because of its effectiveness, its price. A classical case of poisoning in ED, this is why this. So comes with presentations of vomiting, pain abdomen. They are conscious. They are hypotensive. They have metabolic acidosis. Their lactates are very high, and most of them are hypoglycemic. That their blood sugars have gone down. There is no evidence of involvement of kidneys or liver. But as the disease progresses, as the effect of poison progresses, their heart is affected tremendously and fatally. There is strong evidence of deteriorating dilated cardiomyopathy and leading to lowering of the ejection fraction, which comes down to almost 20 to 35 from 55% in a matter of hours. Almost every patient has tachyarrhythmias. Few patients may have hypomagnesemia, and occasional patient presents with pulmonary edema because of the massive fluids that he might or she might have received in a previous hospital where they went up earlier because of hypotension. Now, when we talk about a poison and manage it anywhere, it is very important that we understand what this poison does inside the body. Particularly in aluminum phosphide, it is more important because during 25 years, nobody has been able to invent an effective antidote against aluminum phosphide. Therefore, we take it to understand that nobody has really bothered to understand the real pathophysiology of this particular poison. How does it act on the body? And unless we understand that, as long as we keep speculating, we cannot plan and develop and do research on a real good antidote. Now it is established that the poisoning occurs due to release of PH3 gas, which is called phosphine gas, which is generated by action of the molecule ingested, the element ingested when it comes into action with gastric juice or water or any liquid, from saliva to gastric juice, from mouth to the stomach. Therefore, PHC content of the mother compound has an important role in the intensity of the poison. If the tablets or the pellets outside the body before ingestion have come in contact with water or humid air, probably lot of PH3 has a potential to be lost into the environment before ingestion, and such poisoning will be of lesser severity, less virulent, and the patient actually may not show signs of poisoning. Sorry about that. So I take you through the most probable pathophysiology in aluminum phosphide poisoning. It looks little complicated, but I'll try to make it simple. There is production of phosphine in the stomach from aluminum phosphide. This gas is absorbed very, very fast from the gastric mucosa, enters the circulation very fast. From circulation, it enters the cells, acts at the mitochondria, which is most important. This is factory of a cell. Mitochondria is the ultimate powerhouse factory of the cell. So mitochondria, and probably blocks entry of pyruvate into mitochondria. Again, looks complicated, difficult to understand, but again, I will try to make it simple. Now, this pyruvate therefore accumulates to get converted into lactic acid and so on. So over avalanche of overwhelming lactic acidosis. Now, how does it take place? Now, the same thing it is represented here diagrammatically. We have plasma glucose as the primary source of energy in our body. It is present in all cells, and inside the cell, glucose is converted. Is It comes from glycogen, which is stored in the body. This is the storage form of carbohydrates inside the liver and in muscles. During the process of metabolism, this glucose is converted into pyruvate, and this pyruvate moves inside the cell into the mitochondria. This is the, say, wall of the mitochondria, and it leads to generation of acetyl coenzyme A. This is called TCA cycle, whereas the previous cycle is called Cori's cycle. This takes place in liver and kidneys. pH3, that is phosphine gas, to be seems to be acting here. Now, this probably, since we have lots of production of lactate, that means pyruvate is prevented from getting converted into acetyl coenzyme A, which is the ultimate form of energy leading to ATP production, which is the energy that body utilizes for its functioning. And the end product of this metabolism is carbon dioxide, which is eliminated through lungs, and water, which is eliminated through kidneys. Now, this very cycle is prevented, which is shown by this cross, red cross, and probably phosphine gas seems to be acting either at the cell wall level, preventing entry of pyruvate into this mitochondria, or suppressing the enzymatic activity here to prevent conversion of pyruvate into acetyl coenzyme A, or at both points. The net result is lot of pyruvate is accumulated. There is no conversion of pyruvate into acetyl coenzyme. Therefore, the alternative pathway of energy generation is used in the body metabolism, and pyruvate is converted into lactate. Lactate is highly acidic, it is lactic acid. So, arterial, this lots of lactic acid is accumulated, and this arterial bicarbonates consumed. The bicarbonates in the body produced by kidneys are used by this lactic acid to be neutralized, and the level of bicarbonates goes down rapidly because kidneys are not able to match the requirement of bicarbonates. Therefore, because severe lactic acidosis predominates. Therefore, when we do an ABG, it leaves very low to undetectable bicarbonates in ABG measurements, and it leads to sustained low pH. Usually in these patients, it is less than 7.15. We have seen pH up to 6.8. Anything less than 6.8 or even 6.8 for a couple of hours is usually fatal. It is not compatible with life. We all know that sustained severe metabolic acidosis leads to severe myocardial depression and affects the myocardial contractility, and that reduction in myocardial contractility leads to severe cardiogenic shock because the heart is unable to pump blood into circulation. It is not an obstructive shock, it is not a hypovolemic shock, it is not a neurogenic shock. So there is a severe cardiogenic shock which occurs in cases of myocardial infarction. There is a possibility that this phosphine gas may be inducing some or significant direct toxic myocarditis. Therefore, there may be dual action, one because of severe metabolic acidosis, because of overwhelming lactic acidosis, Second, direct toxic myocarditis by phosphine gas. Ladies and gentlemen, there are lots of probable mechanisms of action, pathophysiological process which have been described in literature, but they are described in a manner that none of them appear quite authentic. They are highly speculative, therefore need not be I would not like to discuss out them here, and there is nothing to talk about them. They are highly speculative without any clinical basis, and they do not explain the whole process like what I have enumerated to you here. So, the sequence of events, there is summary: a massive unchallenged lactic metabolic acidosis leading to acute myocardial depression. All three cardiac major functions are disturbed, that is contractility, that is inotropic action, heart rate and rhythm, that is chronotropic action, and even the conduction defects, which is called bathmotropic effect. It leads to lower LVEF, left ventricular ejection fraction, as low as 15 from 55 within a matter of few hours. Tachyarrhythmias are noted mainly in almost all patients, but occasionally bradycardia is also noted. That indicates that the conduction process in the heart is also affected. However, most of all of these patients maintain a normal sensorium until the last breath they take. And they are talking and they talk sense. We postulate that probably this happens because phosphine gas does not cross blood-brain barrier, or it may not be affecting the sensorial or the motor brain cells. In case sensorium is disturbed, we must look for other causes if the patient has taken another poison, which might be depressing the CNS. Nausea, vomiting, and pain abdomen. This is result of direct effect of the poison on gastric mucosa, irritation. Hypoglycemia is expected in these patients because of relentless vomiting, poor intake preceding the events of leading to suicidal attempts, because the patient must have been quite disturbed for days or hours before he or she has consumed poison, and must not have been taking adequate quantity of food. And there is relentless vomiting. Gastric lavages are done. Usually disturbed glucose metabolism is one probable cause of hypoglycemia in these patients. So let's come to the management very fast. Management strategy. So we have to take action to reduce action of pH3, that is phosphine, at all levels. And naturally, we will have to bring up the hypotension, blood pressure. First, look at that. Administration of antidote if available, removal of the poison left out in the GI, management of shock and other associated complications, interventions that will generate or supply bicarbonates, other symptomatic management strategies, and role and application of ECMO, which has become very, very popular and being increasingly recommended by current age clinicians in aluminum phosphide poisons. Most of this information is derived from case reports or retrospective data. Studies have been published about use of ECMO in ALP cases. We have encouraging data collection presented at many national and international fora, which shows that probably the management strategy that we probably have presented to the medical fraternity may save more patients without application of ECMO. I'm sorry about why. I am not very sure why this is coming very, very light. I hope you can read it. All patients received normally as per international guidelines on shock management, and they receive fluid to the tune of 20 ml per kg of normal saline. However, we recommend use of sodium bicarbonate solution 8.4% as crystalloid and not normal saline as the resuscitation fluid. This contains a very high, that is 20 ml per kg body weight sodium bicarbonate in place of normal saline as resuscitation fluid. This contains very high quantity of sodium as well because it is 8.4% sodium bicarbonate. But we keep resuscitating the patient until the sodium crosses 150. We don't allow sodium to cross 150. Subsequent quantity of the fluid will depend on the patient's response, lung status, that is, if there is any pulmonary edema coming up. If and two main things, that is pH and blood pressure. If blood pressure is still down, pH is still down, we tend to give more sodium bicarbonate in form of boluses, and each bolus would consist of about 200 to 250 ml of sodium bicarbonate 8.4%. However, the cap of sodium not going beyond 150 is always applicable. We would target a pH of more than 7.2 and systolic BP of more than 90. Early vasopressors, noradrenaline and vasopressin would be started as early as possible after early resuscitation fluid has been injected. That is, after say first 500 or 750 ml of sodium bicarbonate has been injected, we intend to initiate noradrenaline therapy and vasopressin therapy if needed, and as soon as systolic BP reaches 90 systolic BP, we add an inotropic agent in form of dobutamine, because the inotropic effect of the patient is compromised very badly. Therefore, an inotropic agent is always needed. The vasopressors add at the blood vessels level, constrict them, which are dilated, and inotropes will act directly onto the myocardium to increase its contractility as much as possible. So that is these two groups of, we don't use any steroids, we don't use any other drug for that matter. So we were inspired by this paper published in IGCCM in March 2009, who recommended give full correction doses of sodium bicarbonate in all cases of Helpos poisoning until pH 7.4 was achieved. This is a very ambitious target and would require huge quantities, much more than 20 ml or 30 ml per kg body weight, which is not possible. And if we do that, most of these patients will end up in hypernatremia, one, and pulmonary edema possibly. That is, both are dreaded complications. All such patients, they reported, survived. ECG changes were reversed. So, full correction dose of sodium bicarbonate will stand in liters, and this may not be without serious compromises. Right. So we would simultaneously also target blood sugar level at 150 to 100 milligram, oxygen therapy only through the nasal cannulas, ET placement, that is endotracheal placement, and ABP use is to be discouraged, because ET placement will lead to create more positive intrathoracic pressure, and their heart is already under tremendous stress and poorly inotropic. There is compromise and dilated cardiomyopathy, and any increase in intrathoracic pressure will end up in a catastrophe. And this is not needed, this is not required. None of these patients are usually have a compromised airway or requirement of ventilator. ABBP is also a, not a successful exercise. It is very costly and it is not available. So correction of hypoglycemia is achieved with 50% dextrose fluid bolus and infusion targeting blood sugar level between 150 to 180. This should be measured every hour because the whole cycle, the fatal period of aluminum phosphide is not more than 72 hours. Either the patient recovers or dies in 72 hours. Most of these patients who die do that. That happens within first 24 hours. The rest of the dying patients, half of them would die in next 24 hours and rest of them would definitely, if they have to die, in next 24 hours. And those who survive, the patients survive more than 72 hours. Oxygen is given through oxygen cannula. Sometimes HFNC may be used again, but this again may create high intrathoracic pressure. These patients never have hypoxia. There is no evidence of their ejection. This SpO2 on the pulse oximeter will always be somewhere around, 92%, but mostly pulse oximeter will not be able to detect their SpO2 because of severe hypotension that they have. However, the ABG has never shown oxygen level below 57, 58. Usually it is around 60 plus. Therefore, endotracheal intubation is not recommended. And we should not understand that these patients may aspirate. It seldom happens. Indicated only if we intend to do mechanical ventilation. Again, our experience with ventilation is very poor, and if we ventilated any patient, none of these patients survived. No antidote is recommended for ALP in literature. The description in literature only says we have used this, we have used that. We have used sodium bicarbonate. Our group has used sodium bicarbonate as I have already described, and because it is the bicarbonate which is reduced in the body, and that is evidenced by ABG measurements. Some of the ABGs show no evidence of bicarbonates, which should be about 24 or more in these patients. Therefore, it is very important that we give large quantities of uh, sodium bicarbonate to these patients, and until more information comes probably to us, to our work, we recommend use of sodium bicarbonate as the ultimate antidote in these patients. Gastric lavage is not recommended. Most of you must be surprised that what I'm saying, but yes, this is evidence based. No gastric lavage is recommended in any poisoning unless the patient arrives within 1 hour of ingestion, which seldom happens. Use of vehicles like saline oil, potassium permanganate solution are not recommended. The literature shows a strong recommendation for this. Use of activated charcoal is not also helpful. Use of whole bowel irrigation is also not recommended. MSS is contraindicated. Use of antiemetics is also not recommended. Now, other than using sodium bicarbonate from outside in the amounts that I have already talked about, we also recommend use of dialysis, that is RRT, renal replacement therapy, which will generate bicarbonates. RRT in any form, maybe SD or SLED or CRRT, will generate bicarbonates. However, with slower processes like CRRT and SLED, it will be very slow. And what SD probably will do in few hours, RRT, other processes will take days. Therefore, we recommend hemodialysis in all these patients. It will generate bicarbonates. It will add fire to the abilities of exogenous sodium bicarbonate that we give from outside, and therefore whatever uh, time, whatever frequency, maximum frequency and duration can be carried out, we do hemodialysis. And 12 of our patients, we did as many as 4 times a day, from 30 minutes to 60 minutes. 4 hours spells are the best if we can carry out. Hypotension is a challenge in these patients. Initiate RRT at the earliest. SD is the recommended procedure of choice. Each spell generates bicarbonates. Generated bicarbonates neutralizes lactic acid and reduces and pH rises, which corrects pH. Myocardial function improves and LVF increases, and so does the BP. Do SD as long as possible, as frequent as possible, from 30 minutes to 4 hours. Allow pH to stabilize. It takes 48 to 72 hours. 8 hourly is the best possible schedule and maximum duration of 4 hours each time. Supplement with additional boluses of bicarbonate solution to target pH of more than 7.2. Now see, there is a beautiful relation, linear relationship between, after each spell of RRT and bicarbonate injection. So increase in bicarbonates, you see, this is the red, uh, the pH slowly improves, this blue dots, the LVF improves with each spell, and so does the systolic BP. And ultimately, it closes up nearly 100, and LVF comes to almost around 50%, bicarbonate level to around 20, pH to around 7.2 plus, and lactate, they come down. So that is what we have shown in our patients. Other tried therapies in literatures are lipid emulsions, hyperinsulinemia, antioxidant therapy like NAC, N-acetylcysteine. NAC is N-acetylcysteine, glutathione therapy, steroids. None of them have been found useful. ECMO in ALP is the current emerging intervention. This cannot be a therapeutic intervention. It gives rest to the dysfunctional heart. It keeps the patient alive until recovery takes place. This is, surrogate of what we do in bypass surgery. The surgeon operates on the heart which is not available for supply of oxygen to the patient. Therefore, an extracorporeal membrane oxygenation system is used, that is heart lung pump. This is the same thing, and therefore, until the heart function returns to normal, fortunately, the whole life cycle of phosphine gas does not seem to be going beyond 48 to 72 hours. So, if the patient can be sustained, life of the patient, the circulation can be sustained for about 48 to 72 hours, these patients would survive. Such groups who are depending largely on ECMO have reported a survival of 70% plus with ECMO. That's less than 70%. We achieved more than 68% survival in our strategy that I have already placed before you. And this paper is coming up very soon. So this is, these are persistent cardiac arrest, refractory cardiac failure. In these patients, we do have refractory cardiac failure, refractory arrhythmias. This is also seen in many of these patients. However, we have antidote, we have renal replacement therapy. Therefore, they do the job as effectively as. So, the final word, coming to the final slide, all patients perish mostly in 72 hours after ingestion. Patient is more likely to survive after this critical period if passed. Our experience shows that prudent use of sodium bicarbonate fluid as resuscitation fluid, renal replacement therapy in form of HD, hemodialysis, and maintenance of euglycemia are likely to lead to better outcome in ALP patients. We strongly recommend against gastric lavage and intubation. Friends, before I end, I extend an invitation to all of you to fifth World Conference on Comprehensive Critical Care coming up Srinagar, J&K from 9 to 12th October. Dr. Parvez Kaul is the organizing chairman of this conference. Further, we are running a toxicology master course certification, for certification, 3 months duration. Registration for this course have already started. You are invited to join this course. This has got a limitation of 50 registrants. I think I do not know how many registrations have already taken. And an important information for peripheral doctors. We are launching very soon a W4C CCF app, which will be available for uh, launching in the Play Store of Google, and through this group of about 20 top doctors in the country, top 20 doctors in the country who have lots of experience on toxicology, will give you 24 into 7 chat opportunities in case you want to know about your patient that may be in your hands. Ladies and gentlemen, IJCP platform, Srion, thank you very much for your patient listening. I have taken additional 6 minutes. My apologies. Thank you very much.
Thank you, sir. And please don't say sorry, sir. That's our pleasure that you're giving this talk at our platform. So, sir, it's been a wonderful presentation from your end. So, we do have some question if you like to take
Yeah.
that up.
Yes, yes.
Yes. So, sir, the first question is, what are the immediate steps in managing a patient suspected of aluminum phosphide poisoning in an emergency setting?
Right. So this is a very natural question. So the first and foremost, do not waste time. There is no time is life in aluminum phosphide because the whole thing is going to finish in 48 to 72 hours, and first few hours are the most important ones. Remember, by the time the patient reaches your center, he does not have any left out poison in the stomach. No patient can reach hospitals within first 1 hour or 2 hours. Therefore, don't waste time on gastric lavages. This takes a lot of time. Time is wasted, energy is wasted, manpower is wasted, which is a scarce commodity. Diagnosis of aluminum phosphide is very important. The symptomatology of nausea, vomiting, pain, abdomen, history, and garlic odor in their smell and from mouth they are the major diagnostic evidences. There is no test There is no test available or recommended to make a diagnosis. There is no laboratory test, there is no bedside test other than ABG. If you have doubt, ABG must be done. It will show you severe metabolic, relative. Initially, it may not be that bad, but you will see that lactic acid may be high, 5, 6, 7, bicarbonates may be little low, pH may be less than 7.3. But as the time will progress, the pH will come down. Blood sugar is also likely to be low. Most of these patients will be hypotensive. So, what I am telling you as management of aluminum phosphide is applicable only if your diagnosis is correct, not otherwise. So, sodium bicarbonate 20 ml per kg body weight should be injected as fast as possible, as early as possible. That initiate, these are available as 100 ml bottles only. So you will have to keep almost 2 liters, 20 bottles of 100 ml. And they should be pushed very hard, very fast, and you should be able to give, if the patient's weight is say 60 kg, or 1200 ml, 12 bottles to be injected in less than 1 hour. So this is a challenging task, and if you can do that, you have won the first battle. And as soon as you have given the first 500 or 700 ml of sodium bicarbonate, initiate noradrenaline therapy. 2 ampoules in 100 ml of NS, and initiate noradrenaline therapy, 20 drops, 15 drops per hour, and titrate them. And if the blood pressure, systolic blood pressure is more than 90, initiate dovitamin therapy, 2 ampoules in 100 ml, and say 20 drops, and titrate dovitamin to these patients to achieve a greater. Now hypoglycemia must also be treated by give 2 ml per kg glucose 50% to these patients, and your target should be 150 to 180 milligram blood glucose level, and that should be monitored every hour. And if you do an ABG, you will also get sodium levels. So keep a watch on sodium levels, and if the diagnosis of sodium, this aluminum phosphide is confirmed, prepare the patient for hemodialysis. Sound everybody who is to be involved so that you don't waste time on that. Call the, or most intensivists these days are equipped, they are mandated to do bedside echocardiography. We call it POCUS, point of care ultrasound. So do POCUS, measure LVEF, look at the cardiac functioning. As the disease will progress, you will find that the patients develop dilated cardiomyopathy. The inotropic function of the heart goes down, BP goes down. That's the initial intervention I recommend strongly. No gastric lavage, no intubation. You will have to pick up samples from stomach for medical legal purposes. Yeah.
Thank you. So there's one last question.
Hmm.
Are there specific antidotes or treatment for aluminum phosphide toxicity? If not, what supportive care measures are most effective?
So I have already said sodium bicarbonate to our study, and there is strong suggestion in literature also that we require to create strong alkalis, inject strong alkalis and generate strong alkalis within the body endogenously. And there are only two possibilities: injecting sodium bicarbonate from outside and generating bicarbonate by doing RRT, and it has to be a rapid RRT. Now, sodium bicarbonate is required in large quantity, therefore, we cannot eat chapatis also, puris also, and parathas also. We have limited diet, limited space available in our stomach. Likewise, we have limited space available in our circulation. So, if we have to use large quantities of sodium bicarbonate solution, we cannot use other solutions. What are other solutions? Other solutions are normal saline, dextrose saline, and fluids which are hypertonic solutions.
Thank you so much, sir, for answering all our questions. That's all from our audience. So, before concluding, any take home message from your end?
Take home message is aluminum phosphide are going to be seen by all clinicians doing clinical practice. The first patient, the first doctor, the clinician visits, the patient visits is the closest facility, small nursing home, gali mohalla, closest hospital they reach. Don't waste time, and you can definitely make a diagnosis. You can definitely administer sodium bicarbonate. You can definitely avoid gastric lavages. You can definitely avoid injection of huge quantities of normal saline or dextrose saline, and you definitely can avoid delays in referring the patient. So do these initial therapies and refer the patient to a competent place where these patients can be handled. Otherwise, death is imminent.
Thank you so much, sir, for joining us today. Thank you again for this wonderful talk. And
My
with your
pleasure.
I would like to conclude today's session, sir. Thank you.
Thank you so much. Can you tell me the number of attendees?
Sure, sir, that I can tell you after the live is done.
All right. So I can log out?